And so I just wanted to welcome everybody to Grand Rounds and also welcome all the folks on WebEx to Grand Rounds as well. It's a pleasure of mine to introduce Dr. Scott Norton and also Colonel Norton to Grand Rounds to give his talk on global health in Jeopardy, an interactive introduction. As you know, he's the Chief of Dermatology, and the recently launched Global Health Initiative. Is excited that he's essentially launching our one of our great chances to put global health on the stage with Grand Rounds, as well as this is also the week for the Global Health course. We typically do it twice a year, in the fall and in the spring, and it's open to anyone who wants to show up. It's primarily geared towards the residents as part of their program and part of their the community health track, in order to be a more global perspective in terms of their healthcare abilities. And so I don't want to take too much time because I know Scott always has a lot to say and a lot from us to learn from.
Thank you, Kathy. Congratulations to you and your team for launching this global health program. And thank you for inviting me to be the inaugural speaker. Just in the way of disclosures, let me say that I regret that I have no financial conflicts of interest. I am a former U.S. federal employee, and my worldview may be colored from those 25 years. And I will mention some off-label uses of drugs and devices. Let me just see here. Okay, so the title, Global Health in Jeopardy, is a double entendre because there are certainly some hazards confronting the health of the globe, and we'll talk about what the term global health means during this talk, but also double entendre in that I want to use this Jeopardy format to make this more interactive, to let you tell us what your knowledge and experiences are with global health. So here are some of the categories that we're going to do, and in the interest of time, I'm going to be the one to select the various topics. Otherwise, we could have people deliberating, do I want to do this for 500 or not? But so the way we'll go through this session is, just like the TV show Jeopardy, you will see an answer that's put in front, and then you have to come up with the question. So the answer in this case is Children's National Health System Global Health Initiative. And the question that you would say is, what is the name of our newly established program in global health? Okay, so we'll go through this pattern for the morning here. And as long as we're on this topic, let me just expand on what Kathy was talking about, that the goal for the new Global Health Initiative is to address the health needs of children and adolescents in our global community through high-quality collaborative research and mutual education. And you know, we think a lot about how the framers of the Constitution chose every word just perfectly. They crafted it so that every word means something. I think that kind of energy went into this here, because I think that knowing how many different ways people look at global health, whether it's delivering primary care somewhere or perhaps doing vaccine development that may seem at first glance at opposite ends of the spectrum, they aren't. And in global health, we want to embrace that entire world of activities that will address the health needs of children and adolescents in our global community, and our global community starts right here in this very building. And so we have Craig Sable and Tanya Paiva to thank for taking on the leadership here, and I want to just acknowledge Andrea Beaton, who is the director of the research side of this, and Kathy Ferrer, who's the director of the educational side of this new Global Health Initiative. And I won't go into this now, but Kathy can get to you all the various mission statements and visions and goals and objectives of this initiative so that you can explore it in greater detail. And she also has some special, some interest group meetings, and she'll get that word out to you as well. But one of the first things that Kathy did was put out this query to our hospital community to find out how many people have been involved in one way or another, perhaps by their own definition, in global health activities. And we see it's really a matter of hundreds of people that we work with consider themselves to be an actively engaged member of the global health community. And they demonstrated by in the last 5 years, we've had almost, our staff have worked in perhaps 100 countries, almost 100 countries. And certainly every day in the emergency department here, I imagine we probably see kids from 100 countries. So this global community really does start right here at our own home. So in this lecture, as we go through the Jeopardy format, we're going to talk about diseases in individuals, diseases in populations, some of the ecological aspects of the disease, and some historical and societal aspects to try to wrap things together. I'm going to go through a lot of vignettes, and I'd love to have the time to flesh out each vignette and carry each lead down and tell you why this is historically important or politically important or economically important, but I'm only going to be able to touch very briefly on those. So let's start with this category, just disease and global health. And here's our first answer. The term for a disease that is appearing for the first time in a particular population or a disease that existed previously but is rapidly increasing in incidence or geographic distribution. What's the term that we use, the umbrella term for this group of diseases?
What is an emerging disease?
What is an emerging disease? And those of you who hesitated, thought you knew the answer, that hesitation is actually correct because the definition of emerging disease is under flux right now. There's a number of groups that have adopted this as an important term, and these are groups like the World Health Organization, the CDC, Public Health Service, NIH, and they all have slightly different definitions. But let me go through my, my definition, which of course is probably the correct one. A disease that is appearing for the first time in a particular population or that existed previously in that population but is now rapidly increasing in incidence and geographic distribution. So we'll come back on that theme quite a few times. But here are some selected emerging and re-emerging infections since the 1970s. I use the 70s as my baseline because that's when I sort of became of conscious awareness of the outside world. And so these are the diseases that started appearing in the 1970s. And many of them are extremely important today. Here's diseases that were first identified or at least became reasonably well known in the medical and public health community in the 1990s, or sorry, in the early 21st century. And just looking at some of the reports I get from the medical journals in emerging diseases, you're seeing names of new pathogens like this that are unpronounceable that are starting to show up again as new diseases in a population or with increasing incidence and geographic distribution. But, you know, many of these diseases have literally shaped the way that human society goes about things. We now have diseases, Lyme disease, and the way it's changed things in the northeastern part of the U.S. and the psychology of many of our patients. HIV, MRSA, Helicobacter. I mean, some of these have led to the Nobel prizes in the last couple of years. West Nile virus, Ebola virus, and several coronaviruses are changing international commerce and transportation and migration patterns. So one question that comes up a lot is, does an emerging disease, is that a tropical infectious disease? Is that like Zika virus? Well, yes, Zika virus is an emerging infectious disease. It's an emerging disease, but not all emerging diseases have that same paradigm where they're coming out of the tropics and they're infectious. There are many other diseases and health conditions that we need to look at that are neither infectious nor tropical. And we'll, again, touch on some of those non-communicable conditions that can and should be considered as an emerging disease. All right. Now, just in in the southeastern part of the U.S., there's a couple diseases that we're becoming increasingly aware of. One is Hansen's disease or leprosy, and that is becoming endemic, where you actually have transmission right here in, let's say, 2 states south of us, because the disease now, it was once restricted only to humans. Now it has another mammalian reservoir, and that's the 9-banded armadillo that originally did not live in this part of the country, but has come farther north due to man's insertion of human activity into the environment, changing the agriculture and residential patterns, and these armadillos are migrating farther north from Central America. They're now in many of the states in the southeast, and they harbor the leper bacillus. So we do have people who are acquiring leprosy in North Carolina, Georgia, Texas, without ever leaving the state, without ever being exposed to an individual who has leprosy. And so on the right-hand side, we have this column that just tells you some of the ecological dynamics that are going on, and I say dynamic in like a sense of constantly shifting background that are leading to these emerging diseases. Another disease that for a while is thought as being fairly localized in the Gulf of Mexico, this Vibrio vulnificus infection. That Vibrio lives in warm, salt water. Well, at one time, warm, salt water could be defined as almost like an equatorial zone, perhaps going up to the Gulf of Mexico. But now we're finding with climate change and warming trends that the Vibrio is able to survive the trip across the Atlantic on the Gulf Stream, and we're now seeing Vibrio vulnificus infections in Scandinavian countries in the summertime when the warm Gulf Stream waters are coming up there, which is for many people unthinkable, but that's what's happening with the changes that we're seeing in our environment, whether man-made or part of a natural cycle. And going back to Zika virus, we're thinking of this now, we're seeing it in our own hospital. These are from patients who are visiting relatives in Brazil or Costa Rica, Nicaragua, but we have to be aware that the CDC and NIH and virtually every public health organization in the country is very focused on what is anticipated to happen in the summer months as Zika may come north. Now, how could it come north? Well, one of the things is we have the vector here, which are this couple species of Aedes mosquitoes. They're not out right now, but they will be out in a couple months. And we have the reservoir, which is humans. Now, some people think of this as perhaps the disease coming north from Brazil this way, but it doesn't have to come north, because in our global environment, we could just have one Brazilian or Honduran come up and just come to Washington and get bitten by one of those Aedes that are here, and we will have our own local focus of transmission. So the CDC is mapping these things out, and we're seeing that some areas scattered across the country are anticipated to being their own little hubs of nidus, of Zika virus infection, perhaps later this summer. So more to come on that from every public health agency we have. All right, the next topic is water and global health. Here's the answer. It is perhaps the next disease to be eradicated. And you can just sound out if you know what that is. You might know it from the text, the next disease to be eradicated, if you know some of the global health programs, or from looking at this pathognomonic photograph. What is guinea worm? Yes, who said that? Very good. Also called dracunculiasis, and it is a parasitic infection with Dracunculus medanensis. Now, this is a nematode. It's a worm that gets to be about this long, and it has a very unusual life cycle, or distinctive life cycle, that makes it eradicable. So when we talk about eradicating a disease, this one's the next one to be eradicated. The Carter Center, World Health Organization, and other number of other organizations have for decades recognized that the particular life cycle this organism has gives you several points that we would say are strengths for us or weaknesses for the parasite, in which you can influence the dynamics and interrupt the transmission of the life cycle. So guinea worm is found, at one time it was found across dozens of countries, but usually in areas where water is year-round or seasonally scarce, and where everyone would have to go to a single water source at some point during the year. So even if you're in some area like South Sudan that may have a rainy season, in the dry season everything shrinks up and people have to come to these, we'll just call it an oasis, that's what we're looking at in this picture here, to get the water that's necessary for every human function. And so people would go into this water, and if they had the parasite in them, that parasite would actually start emerging, like you saw in some of the earlier photographs, would start emerging and release its larva, the next generation, when the parasite goes into that water. And then people have to go there to get their drinking water, and in fact, they walk in to get their drinking water, and that's how the parasite releases the larva, and then you get your drinking water and you drink that, and through several steps I won't go into, you wind up acquiring the infection, and that has very high morbidity, very low mortality. But you know, that's an interesting point, because we in the West often focus on mortality, but you know, cumulative morbidity and loss of your active life, that can cumulatively cause as much economic or medical distress to a community as the death of an individual. So what the places are that one can interrupt the transmission here is, you can tell people, don't go into that oasis to get your water. Use a bucket. The second thing is, don't drink that water straight out of the oasis. Put some sort of filter on your drinking vessel. What kind of filter do you need? An old T-shirt, a hand-me-down that says Washington Redskins Super Bowl champs 2014. You get those T-shirts that are cast aside, and you can just use that to filter the drinking water. And then there's a couple steps to just keep the water clean there. And that alone, those three interventions have reduced guinea worm from 125 million cases 50 years ago or so to about 50 million cases 50 years ago to about 125 cases last year. And there's only a few places left that have the guinea worm. And is it eradicable? Well, in theory, yes, it's very easily eradicable. But the problem is the 4 countries that still have guinea worm are failed states, where it's like South Sudan and Chad, where it's very difficult to get any public-spirited endeavor into those places. So we may wind up having several foci around for decades, as long as those countries resist public health efforts. Okay, the cause of epidemic cutaneous and visceral malignancies in Bangladesh. So skin cancers and visceral cancers. And who said that? Very good. So what is chronic arsenism or arsenic poisoning? And this is a story that comes out of the Washington Post, although you could read it in any of the international health literature. But so this is, I'll just quote from the Washington Post. Thick black warts tattoo the palms of this woman. They're very painful, and it's the result of drinking arsenic-laced water from her village well in Bangladesh. Actually, I'm going to skip through all the text right here and tell you the bottom line is that World Health Organization has a wonderful research institute that just studies diarrhea. And if anyone wants to apply for a fellowship there in diarrhea, you would apply to Dhaka, the capital of Bangladesh. And why do you have so much diarrhea in Bangladesh? Well, there's lots of reasons, sort of sanitation and also the water. Bangladesh is very low, and every year there are storms that cause flooding from the estuaries, from the ocean, from the reservoirs, from the rivers to the drinking water. So no matter what you try to do to keep poop and drinking water separate? You can't. And so there's always diarrhea going on there. So the worst form of diarrheal illness is cholera. It can be fatal in a day. And it was discovered that in Bangladesh, if you could drop a well down through the bedrock, you could reach an aquifer that has no fecal pathogens. You can get pure water there. So that was fantastic. And a lot of agencies came in and dug these wells down 100 feet or so, these villages, going through the sort of the stagnant, polluted water there, down through the bedrock, into the bedrock, and getting this water. So here we have pure water. The problem is there's natural arsenic in that bedrock, and that was not detected. People had looked for all the fecal bacteria. And so now for the last 40 or 50 years, people have been drinking water with extremely high levels of arsenic. And some of the consequences of chronic arsenism is the development of epithelial cancers of the skin and the viscera. And going back one slide here, the World Health Organization calls this the largest mass poisoning of a population in history. The magnitude of the problem is 50 times worse than in Chernobyl. And so these are some of the unintended consequences of trying to get healthy, sanitized water to people, leading to some unanticipated problems that may be as large as the original problem that you tried to take care of. So this is an emerging disease, and this is not infectious. And the whole idea of trying to get water out to people is really so important. Some people say that may be the theme of the second half of the 21st century, that gets the world's focus the way maybe oil prices have gotten the politicians' focus for the last 20 or 30 years. There's so many examples of trying to get water out to people for hydroelectric power, for clean drinking water, for irrigation for agriculture, and dams are created. Well, dams may be wonderful for getting the water for all these economic purposes, but, you know, the immediate consequence is people have to move. So you have these Three Gorges Dam in China that people are reading about, that where 20 million people may have to move once those rivers are dammed up to get the water for hydroelectric power irrigation. But that scenario has played out a number of times, and two of the biggest occasions are the Aswan High Dam in southern Egypt, where the Nile was blocked up. It prevented some of the Nile flooding. But, you know, the Nile flooding has sustained the Middle East or Egyptian economy and lifestyle for thousands of years, millennia. And by blocking the Nile and preventing these annual floods, you could always get water for irrigation, but you're changing the lives of millions of people. And schistosomiasis is one of the infectious diseases whose life cycle requires still waters, because you have to have snails there. And so before, when the Nile was flowing, you had some schistosomiasis, but not a whole lot. Now that you're damming up the Nile, you have all these huge reservoirs that are just the perfect environment for that schistosome life cycle. And in West Africa, in Ghana, one of the rivers there, the Volta River, has been dammed, again, for hydroelectric power, and provides lots of ample drinking water and water for irrigation. But one of the bacteria that can live in the fresh water there is this unusual mycobacterium, M. ulcerans, that causes Buruli ulcer. And as you see the kids in this public health poster playing in the fresh water, every time, if they get an abrasion on their skin, they can get this bacteria in there. And this is a very insidious, virulent bacteria. Insidious meaning it works slowly and sort of under the surface, but virulent in that it actually causes necrosis of tissue, and it creates these huge ulcers that are extremely painful and really don't have a good cure. So now you've got these kids who have these huge ulcers. They can't go to school. They can't work in their family's farms. And when the ulcers heal up, you wind up with contractures that probably render this person to be, I'll just say, economically useless in an agrarian environment. And that's one of the consequences of, unintended consequences of this dam. And so when you think about it, how much is a bottle of Fiji water? It's like $4 for a quart or something. And how much is a barrel of oil? It's $30 for 55 gallons. So water already is more expensive, more precious than oil. And with all the changes that are going on in land use and water use and climate patterns, we're going to wind up with huge conflicts over water rights. And anyone here who's from Arizona, Utah, Colorado, California knows that those states are driven not by tourism, they're driven by water. Water makes those states live and die. And that same principle is going to probably expand to many, many other parts of the world. Okay, now we'll shift into another topic, animals and global health. The 3 species necessary to create a strain of pandemic influenza. If you know one species, you can mention that. I know one, humans. Okay, your turn for 2 more. Pigs and birds. So what are birds, pigs, and humans? So when we think of influenza, we're worried about flu going from one kid to another in school, that sort of thing. But really, from a global health perspective, we worry about the mixing of several influenza viral genomes that go through this every year, where you see that the virus starts out in bird populations, often ducks, and 2 other species are vulnerable to that particular type of avian influenza virus, pigs and people. But people really need to have the pigs serve as this recombinant factory for that avian influenza virus. And so what you'll wind up with is a virus that goes from the bird to the pig to the human. And you've heard about swine flu and you've heard about avian flu. Avian flu is dangerous because it can go directly from the birds to the people without needing this intermediary to sort of be the cauldron of bad viral genomes. And why does influenza always come out of Southeast Asia? Well, in Southeast Asia, Cambodia, Vietnam, Indonesia, Thailand, those are the places where you actually have people, birds, large populations of birds, and pigs living in close proximity. So if you look at this house up here on stilts, down below is where the pigs live, and there's ducks that are there, and they all just live together. So there's just the perfect scenario for developing this recombination of the influenza genome. And then once we've got this new strain that gets into people, and if it can go from person to person, then you have a type of flu that can become pandemic. Good. Now, this theme is animals and global health, and it makes me think about still one of the major diseases in global health. I guess the 3 biggest diseases in global health are considered malaria, HIV disease, and tuberculosis for total morbidity and mortality. And we see this, all these public health efforts that malaria can be prevented and controlled. They're talking about getting rid of the mosquito breeding areas and sleeping under mosquito nets, that sort of thing. So can we use these principles to help prevent the spread of Aedes and Zika virus in the U.S.? Well, yes and no, because the mosquitoes that transmit malaria are anopheles, and they have certain behavioral patterns like biting at night more often, and Aedes, and living probably more out in areas where there's large bodies of clean water, whereas Aedes is a urban or peri-urban mosquito that likes just little bits of micro puddles of polluted water, and it bites during the day. So because they're both mosquitoes, you might be able to use some of the principles for controlling those diseases, but they're not, the principles aren't exactly interchangeable. Now, why do I show this red fruit over here on the right, well, this is the African oil palm, or produces palm oil. And on the lower image, you see just bottles of palm oil that are for sale. And if you go into any sort of African grocery here in our part of D.C., where we have so many West Africans, you'll find these jugs of palm oil that are for sale. And the palm oil is this oil that comes from a particular palm tree that's native to West Africa. And the oil is distinctive because of its bright orange, red, magenta color. It's all from all the alpha and beta carotenes that are there. But, you know, this oil can be used for more than just cooking banco or fufu or some other West African dishes. This can be used for all sorts of culinary purposes and industrial purposes, and it's become a very profitable crop. So when we hear about land in Brazil or Indonesia that's being chopped down for the stuff's being chopped down to log the wood and then to put in agriculture, the two main crops that are being put in are soybeans and palm oil. And so while I've been talking, there probably have been several 100,000 acres of land in Indonesia and Southeast Asia, perhaps Brazil as well, that have been completely logged so that they can grow the oil palm. Well, one of the consequences of that is that now we're getting human populations that are getting closer to the jungle where people didn't live before. And in the last few years, some of you may have heard about a fifth species of malaria. You know, there's typically just 4 species of malaria that go to humans. But there's a fifth species now, Plasmodium knowlesii, and no one really knew how that started showing up. It was always in Southeast Asia, and now it's known, and the life cycle makes it also obvious. This particular species of malaria is found in non-human primates in the dense forests of Southeast Asia, and it has its own species of mosquito, of Anopheles, that will transmit it. And ordinarily, people and that particular Anopheles would never get together. But now, as the interface between, you know, devastation of the environment and the human populations gets pushed out there into the jungle, people are now the closest primate for, or the most abundant primate for this particular mosquito. So that mosquito has now recognized that these new human populations, hey, that's good stuff. And they have now bitten enough people and transmitted enough malaria, this one species, that it's now considered an established fifth species of malaria as a result of these land use changes. So we'll be hearing more about that as well. Next question. From Time Magazine's cover in December 2014, the person or people of the year, what were they called? I have it covered up here. I mean, you all know the answer. They call them the Ebola fighters. And that was the big public health story, global health story of the last year or two. Well, I want to just talk about the way we look at the Ebola fighters. So Time Magazine had about 5 different covers, and they all were doctors or nurses who were in there, in the trenches, in those tents, in this tie-back suits, taking care of people and doing amazing things. And we were certainly very much aware of that. I remember having our Roberta DiBiase giving us a lecture on how to put those tie-back suits on. Well, for every physician involved in controlling Ebola, there were probably at least 10 non-physicians who were there making sure that physician could do his or her job. So there were truck drivers, transportation, cooks, security people, people who took care of the tents, the water supply. So when we talk about Ebola fighters, it's far, far more than our sort of ethnocentric view of being the person who's providing the direct health care. There's a whole team. But there's more than just that team, because Ebola is a zoonosis. And a zoonosis is a type of disease that ordinarily has a complete life cycle in a non-human animal and then can spill over into humans. So that Plasmodium knowlesii, the fifth species of malaria, has spilled over from an animal disease to now human and animal disease. So we know that about 70% of all emerging diseases are spillover pathogens that normally have a complete life cycle outside of man. And that concept holds true for Ebola as well. So I'm going to introduce to you a new term called One Health. Now, it may sound kind of gimmicky, but this is the term that's been adopted by the World Health Organization, the Public Health Service, CDC, NIH, that requires us to look at disease and health not as just pathogen human and not just keeping kids healthy like we look at also, but it's keeping the environment healthy and keeping the animal populations healthy, both the wild animals and domestic animals. So with Ebola, one of the things that's been so curious about this is that it shows up about every 20 years in a different part of Africa. Where is it in that interim? It's not in people. It's in some other animal that's the reservoir for Ebola. How does it get from Congo or Sudan or Uganda over to Liberia? I mean, that's crossing a couple thousand miles. We don't know. No one knows what the reservoir animal is. There's thoughts that may be bats, and here we see people in the DRC out at night catching bats, and they've caught tens of thousands of bats. And only 2 or 3 bats have ever been found to have Ebola virus in them or Ebola antibodies. So even though this outbreak in Liberia last year may have been carried by a bat, there's a possibility it was, very few bats have Ebola, and that cannot be the reservoir for Ebola. In fact, the Smithsonian went back and looked through 70,000 African bats doing PCR on them and found no Ebola in any of those bats in their stuffed bat collection. Hey, a charming place. Okay, and how do people, but a lot of diseases are transmitted by bats to humans. Certainly SARS, MERS, a number of other diseases are as well. How do we get associated with bats? Well, in many areas of the world, bats are part of the bushmeat market. And here's a picture in Cameroon, and throughout Equatorial and West Africa, bats, many species are consumed. So if there are diseases that are found in bats, they can easily jump to humans. Here we have a nice pot of bat chowder, and here we have a vaccination program to vaccinate mountain gorillas and lowland gorillas against Ebola. So we don't have a human vaccine for Ebola, but there are some experimental vaccines for these large non-human primates that also can be devastated by Ebola the same rates that humans can, 80 to 90% devastation. But no one knows where the Ebola comes from. So the veterinary community and ecologists and mammalogists and botanists are getting involved into this concept of One Health. And so in the middle paragraph, the One Health approach examines emerging diseases from a perspective that looks at human health, animal health, and environmental changes. And this term, just like global health is a term that kind of has evolved over the last decade, One Health is a term that is now mainstream in certainly in the public health world. So this is the sort of Venn diagram for One Health, and all these disciplines are necessary. Just going back to that image of the bat chowder there, I met an anthropologist who worked in 3 communities in Liberia, Sierra Leone, and Guinea, and for 3 different ethnic groups, and she looked at their dietary patterns. It was fascinating because each of those groups were from a different ethno-linguistic group, and they all had their own laws, dietary restrictions. They all kept kosher in different ways. And one group would eat monkeys and rats but not bats, and one would eat monkeys and bats but not rats, and one would eat rats and bats but not monkeys. So she's studying those communities to see if there's different patterns of disease transmission there based on just the dietary patterns. So there's lots of drivers for the change in human health, environmental health, and animal health. Not enough time to go into that. Arthropods and global health. Time magazine let's see, this is a couple years ago, they had a list of the top evil animals. So Dr. Evil didn't even make the list. What was the top evil animal? And we see a picture of it right here. They said, what are bed bugs? Yes. Okay, so people do not like bed bugs, but you know, we as medical people should realize that bed bugs don't even deserve to be on that list. I mean, what do bed bugs do other than just give you some itchy bumps like this? So the question I have is, do bed bugs cause any diseases? And I'll say that the indecision that you're giving me is correct, because there's a couple ways you can answer that, and I deliberately chose an ambiguous question. Sure. Well, one answer is that bed bugs do not transmit any diseases. Do they cause any diseases? Yeah, I'd say. They cause itchy bumps. That's a disease. You can get impetigo from that. Psychological impact of this. There's the economic and societal costs of bed bugs. They're huge. So those are legitimate health conditions. But are there any associated pathogens? And again, you could argue yes. If you take a bed bug that's just fed on some syphilitic individual, you can recover the spirochetes there. You can find HIV and hepatitis viruses, but does it transmit any of those? And the answer is no. By epidemiology, by the behavior of the animals, by the biology of the diseases, there is no evidence that bed bugs, no matter how much blood they take, can transmit a disease. And that's because bed bugs are not, they're not syringes, okay? A syringe, you take blood and you can stick it back into someone. Some animals, some vectors are like that. A lot of mosquitoes are that way, sandflies that transmit leishmaniasis are that way, but a lot of insects are not vectors for any disease because of their behavior. First of all, once a bed bug gets a meal, it may not need to eat again for a year. So it's not likely, and none of the pathogens can have a life cycle that allows them to either multiply or even survive for that 1 year. The second thing is, bed bugs aren't like mosquitoes that regurgitate things. Bed bugs defecate stuff out. They don't, their proboscis works well. It just sucks things up. In mosquitoes and sandflies and many other organisms, when they're carrying these bad guys, their proboscis is a two-way street. They're getting blood up and the pathogens are going down. Bed bugs don't do that. And that's one of the reasons why bed bugs are not transmitting diseases. But many other arthropods, of course, do. And so I show pictures here of Aedes, the mosquito that transmits Zika and yellow fever and chikungunya and dengue and a few other diseases as well. So we've already seen a couple patients in our emergency room who have had this type of rash, this morbilliform, some people call it maculopapular eruption. A couple kids have had this, and they've had Zika virus infection. It's been confirmed coming back from Central America. We'll be seeing more of this, and remember, I was talking before about Anopheles transmits malaria. Aedes transmits these viral diseases. So even mosquitoes are not flying syringes. The pathogens, the vectors, and the hosts all have to be sort of synchronized evolutionarily over millions of years. So there are thousands of diseases that our veterinary colleagues need to know about that can be transmitted by mosquitoes that bite us. But we don't get those because we are not what's called a competent host for these sorts of organisms. And so just the mere presence of an arthropod, like the ticks that transmit Lyme disease. Why don't mosquitoes transmit Lyme disease? This is a complicated thing. There's scientists at NIH who just studies insect saliva and what the saliva does to the pathogens, whether it promotes the growth or destroys it. So I mentioned that the bed bugs defecate out. Here's my This is what happens if you have too much time to do PowerPoint on an airplane. So I'm showing the trypanosome bug that transmits Chagas disease, and this does, when it feeds, it actually defecates out the pathogens there, and what happens then is you get this little itchy bump there, like it feels like a mosquito bite. You scratch it, get a little bit of that bug feces on your fingers, and then later on in the day, you just rub your eye, and that's how you transmit Chagas disease through one of the common portals of entry, which is just the conjunctiva. This Romagnus sign that we see on your right is not from the insect biting there, it's from the child just scratching a bite and inoculating it. So I put this disease in here for a couple reasons. One, this concept of the evolutionary ties between vectors, pathogens, and hosts, but also because Chagas disease is having an expanding range. You know, you look at some old maps, and you see it in Paraguay and Bolivia, but now it's throughout Central America, Mexico, and we are now seeing indigenous transmission of Chagas disease in Southern California and South Texas because we have the right vectors, we have the pathogens now, and we have a competent host, humans, in those areas. Of interest is that the competent vectors, the particular insect here, lives all the way up in the U.S. to about the middle of the country. So maybe from San Francisco through Kansas City to Washington, D.C. So we may be seeing this not only in patients who immigrate from endemic areas, but it soon may be endemic here because climatic change and environmental change is permitting it to be here. Okay, this document, encouraged by the World Health Organization and created by each participating nation, identifies for each country which medication should be available in that country and at what level in the healthcare system. And I'm going to take a guess by seeing this title, Essential Drug List, and I'll ask the question, what is an essential drug list? And that is correct. So the World Health Organization has created something that we don't know about in the U.S. I gather there may be some economic disincentive to have one of these in an affluent country. But what's essentially happening here is the World Health Organization has asked each country to figure out what medications it wants to have in that nation, and then decide how to allocate those medicines in your hierarchy. So you may have some salvage chemotherapy drugs only at 1 or 2 hospitals in the country, but you may have some standard antibiotics, Bactrim, doxycycline, all the way out at the smallest community hospital. This shows in detail for the country of Guyana, just some of the dermatologic drugs. Some are restricted to the National Medical Center, and some go down to the community health worker who's only had perhaps a week of training, and they're authorized in that environment to use these medicines. The medicines are chosen because they're shelf stable, they're the right, they cost an appropriate amount, they have fewer side effects, et cetera, but again, in the U.S., Canada, UK, France, we do not have an essential drug list. So if you ever go traveling abroad to work in some other country, I always try to get the essential drug list first before I go there so I know what's available or what should be available. How often are those medications available at that particular level? Well, it depends on the country. You know, some of them have very nice documentation, but no medicines. And in some of those countries, we find that there are alternatives to getting your health care. So these are some pictures, some from me, some from fellow University of Arizona, on some of the alternative clinics that you can find in Ghana. So here, this Dr. Dua can treat everything from joint pains to inability to give birth. And this is an interesting photograph. It shows a young man urinating blood. That sounds crazy. Why would he be doing that? Schistosomiasis, sure. In many of these countries, all boys have acquired urinary schistosomiasis by the time they're 10 or 12 years old. So about the same age that the young ladies in their community are having their first menses, these boys are having their first episodes of hematuria. And here's Fred medicated soap that I saw at a market in northern Ghana. It can take care of every sort of rash you can imagine. Dr. Cor Bramble, we're arranging our budget next year to get some of this in. Okay, so anyhow, the alternatives to a proper healthcare system are varied, and some of them are traditional medications. But what I wanted to raise here is one of the important issues in global health is that there are so many counterfeit medications that are out there. You can go to some countries like Nigeria, for example, where all those impoverished Nigerian princes are trying to get you to help them recover their riches. But Nigeria, probably half the medications that you buy there are counterfeit in some way. They're not manufactured by the professed manufacturer, and sometimes they have the medicine in there but just impure. Sometimes they don't have that medicine. Sometimes they have other medications in. One study in Nigeria showed that about 1/4 of all birth control pills had zero hormonal activity, which would be very shocking to many people, and about 1/4 of vaccines sold in Nigeria have no antigens in them whatsoever. So the medications that we have abroad, that is a huge problem, and we talk about resistance to antibiotics. Much of that emerges from the developing world where you might be able to buy proper antibiotics improperly without a prescription and start using them for whatever ails you. Poverty and global health. Collectively, these diseases affect several billion people, but have been historically ignored by Western biomedical research. So what's the umbrella term for these? What are neglected diseases? Yes. So what are neglected tropical diseases? And so examples are leptospirosis, typhoid, and dengue. And this is a term that, again, the World Health Organization and NIH and the CDC have adopted, and it's a group of diseases, depending on which organization, there's different numbers, anywhere between 12 and 25 diseases that are widespread in areas where there is an inadequate healthcare system and where the infrastructure is not likely to do much about these diseases. So essentially, these neglected diseases are diseases of poverty, and billions of people have them. And many people have several of these diseases. Here's just a list of some of the diseases. I have broken them down by pathogen, which is kind of a by pathogen class, like virus, parasite, protozoan, bacteria, et cetera. That's a very artificial way to look at things. It really should be looked at which ones are waterborne, which ones are fecal-oral, which ones are arthropod-borne. But you can see a lot of these diseases we just don't see here. But if you have literally hundreds of millions of people with scabies getting secondary bacterial infections, that's a serious disease. And it turns out that we have some very inexpensive medications that can take care of a number of these diseases. So for the cost of about $1 a year, you can give people a triad of medicine that will control, in some cases cure, in some cases control many of these diseases. So this is a big pitch in the world of neglected tropical diseases. And because we're getting close to the end, I think I may end with this little vignette. Which health concerns should you address first if you are in a place like a failed state with a failed healthcare and failed medical system? This article appeared in New England Journal 30 years ago when Ethiopia had the worst healthcare of any nation, and the conclusion was the best way to improve the health of the people is to get rid of the doctors. And that may strike you as counterintuitive, but doctors get paid and their salaries are higher than that of the community health workers. The doctors take care of individual patients, but the community health workers take care of communities. And what do the community health workers address? Immunizations, clean water, oral rehydration for diarrhea, breastfeeding, sanitation. And those don't cost much money at all, and you can get more bang for your buck by getting rid of the physicians and putting your emphasis into these areas. Let me jump to my last. Okay. This was regarded as the most lucrative medical enterprise in 1954, an unlimited growth industry. Invest all your money in this drug or device, and you will make money for the rest of your life. What was touted as this unlimited medical growth industry in 1954? And the clue here is not 1954, it's the next year, 1955. What happened then that ruined good capitalism?
Iron lung.
What is the iron lung? Who is this man here? Because in 1954, polio was out there, and when you talk to your parents about what it was like in the summertime when you couldn't go swimming because there was a fear of polio, a fecal oral virus, because many communities were having such high incidence of polio that was causing respiratory paralysis that people went into an iron lung. And it was presumed that with a good iron lung, you could sustain that life indefinitely. And people knew back then that this was iron lung 1.0. But when you get Wi-Fi enabled iron lungs and air conditioner iron lungs and iron lungs that have places where you could actually go to the bathroom in them right there, and places that may have a wet bar right next to it, just think of all the changes you can make in the iron lung every year, and you know that you would want your family member to have the best iron lung available. So that was the most lucrative medical enterprise in 1954, and people involved in global health, Salk and Sabin and others who worked on the polio vaccine, changed the world. And I am so excited that the executives here have decided that we're going to start a global health initiative, and I know that Dr. Batshaw has high expectations for us, and you can go back and look at the mission statement that he has. He's not talking just about going out and providing one-to-one care. That is simple stuff. We want you to do that because that's very rewarding, but we want you to think about health care globally and think like Salk and Sabin did, and you can do this, and we can do this. And so in this talk on global health now, I've introduced so many concepts. We could talk more about each of these. I'm eager to have Kathy and Craig tell us what the next steps are. And I think right now I can take questions. I'd like to have Kathy come up and join me.
Scott, that was just a fantastic lecture. I don't think I've learned as much in an hour ever as what you taught all of us. And I just would like to say to all of you how excited we are about this new initiative that was brought forward really by Craig Sable as his vision. I know many of you in the audience have actually started to work for many years in the area of global health. And our real approach now is to try and give you the support that you need to do it, and to think from a strategic point of view rather than each of us individually thinking what we can do to help heal the world, but to do it in a more conceptual framework. And I think there is so much to do, and obviously we can't do all of these things, but with your own passion and with the support of this new program, I really think this is going to be a wonderful new initiative. And thank you for really starting this all in a most public way. Thank you.